Welcome to Enormous Nephrology. This is the Hypertension Series, which consists of a series of talks that I've delivered during the meetings of the Hypertension Task Force, which meets once a month at Stroger Hospital of Cook County to discuss strategies as to how blood pressure targets can be achieved in the Cook County patient population. All of my talks, whether they're on hypertension or many other interesting nephrology topics, can be found if you visit my YouTube channel at youtube.com/@irfanmoinuddin-kidney. The current talk is on the ACCORD trial. We have already discussed introductory material on hypertension, the KDIGO hypertension guidelines, and the SPRINT trial. This talk will focus on the ACCORD trial, what we learned from the ACCORD trial, what remains unknown, and strengths and weaknesses of the ACCORD trial. The expert panel hypothesis was that lower systolic blood pressure goal would reduce clinical events more than a standard blood pressure goal. And the SPRINT trial was designed to investigate this hypothesis in several subpopulations as well as the general population. The ACCORD trial investigated whether therapy targeting normal systolic blood pressure, less than 120 millimeters of mercury, reduced major cardiovascular events in type 2 diabetics at high risk for cardiovascular events. The primary composite outcome was non-fatal myocardial infarction, non-fatal stroke, heart failure, or death from cardiovascular causes. So 19,716 participants were screened, and then they were subsequently enrolled in a glycemia trial where intensive glycemic control versus standard glycemic control was being tested. And then patients were enrolled in the blood pressure trial. The patients that were enrolled in the blood pressure trial was around 4,733 participants. 2,362 were randomized to intensive blood pressure control. 2,371 were randomized to standard blood pressure control. As you can see in the intensive glycemic control, the target A1C was less than 6. In the standard glycemic control, the target A1C was about 7.0 and less than 7.9. Half the participants were in the intensive glycemic control, and half the participants were in the intensive blood pressure control. That's how the study was planned, and that was how the study was designed. The inclusion criteria for ACCORD BP was that the participant had to have type 2 diabetes mellitus with an A1C greater than 7.5. The systolic blood pressure had to be between 130 to 180 millimeters of mercury on 3 or fewer blood pressure medications. Age of at least 40 years with cardiovascular disease, or 55 years of age or older, and increased risk of cardiovascular events as defined by anatomical evidence of substantial atherosclerosis or albuminuria or left ventricular hypertrophy, or 2 additional risk factors such as hyperlipidemia, hypertension, smoking, or obesity. Patients with body mass index greater than 45, serum creatinine greater than 1.5 milligrams per deciliter, or other serious illness were excluded from the study. This was a non-blinded trial. Participants were randomly assigned to intensive systolic blood pressure target of less than 120 millimeters of mercury or standard blood pressure target of less than 140 millimeters of mercury. Participants in intensive therapy group were followed up once a month for 4 months and every 2 months thereafter. Participants in the standard therapy group were scheduled at months 1 and 4 and every 4 months thereafter. All antihypertensive regimens were to include drug classes that have been previously shown to result in a reduction in cardiovascular events. Specific drug regimens were not studied, only systolic blood pressure targets. Antihypertensive medications were donated by pharmaceutical companies listed here. Sphygmomanometers were donated by Omron Healthcare. However, pharmaceutical companies or Omron Healthcare did not affect the interpretation of results, and the interpretation remained unbiased. These are the baseline characteristics of the participants, and these are pretty much non-significant. All of the characteristics, including age, gender, race, education, previous cardiovascular events, previous heart failure, cigarette smoking status, weight, and body mass index, were similar amongst the intensive blood pressure control group and the standard blood pressure target group. These are more baseline characteristics. The average systolic blood pressure was 139 millimeters of mercury in both groups, and the average hemoglobin A1C was around 8.3 to 8.4, similar in both groups. The median urinary albumin excretion was 14 to 15 milligram per gram. The interquartile range for albuminuria was about 7 to 45 milligram per gram, so relatively mild levels of albuminuria. As you can see, the mean blood pressure achieved in the intensive blood pressure target group was around 120 millimeters mercury, and the blood pressure achieved in the standard blood pressure target group was around 135 millimeters of mercury. And the number of medications in the standard blood pressure target group was about 2.3 versus 3.4 medications in the intensive blood pressure target group. As far as the adverse events that were reported, hypotension, syncope, bradyarrhythmia, hyperkalemia, hypokalemia, as well as acute kidney injury were more common in the intensive blood pressure target group. As far as primary and secondary outcomes are concerned, the primary outcome was non-significant, as were secondary outcomes of myocardial infarction, death from any cause, from cardiovascular cause, primary outcome plus revascularization or non-fatal heart failure, major coronary disease event, fatal or non-fatal heart failure. However, stroke was less frequent in the intensive blood pressure control group, and this was statistically significant. So this just shows you visually that the primary outcome was non-statistically significant. So it was not different between the standard blood pressure control group and the intensive blood pressure control group. Non-fatal stroke was significantly less frequent in the intensive blood pressure control. Other secondary outcomes were not significantly different amongst the two groups, the intensive blood pressure control group versus the standard blood pressure target group. This shows you the non-fatal myocardial infarction. This shows you that death from cardiovascular disease was similar in the intensive blood pressure target group as well as the standard blood pressure target group. So the conclusion from the ACCORD BP trial was that intensive blood pressure targets did not afford any benefits in terms of primary outcomes or secondary outcomes, and that standard blood pressure targets of less than 140 millimeters of mercury were the same as intensive blood pressure targets, and therefore intensive blood pressure targets should not be pursued. However, the conclusion of the ACCORD-BP trial that intensive blood pressure targets are not associated with decrease in major cardiovascular events in type 2 diabetics is actually clouded by the fact that patients were randomized to the intensive glycemic target versus the standard glycemic target. And this study by Sugimoto and Kajio in Hypertension 2018 shows that the primary outcome in patients receiving standard glycemic control, so if you just analyze the patients randomized to the standard glycemic control arm, that the primary outcome does show improved event-free survival in the intensive blood pressure target group. And in the intensive glycemic control, that's where the data is non-significant. That's where intensive blood pressure control is not associated with the reduction in cardiovascular events. So it's the intensive glycemic control which is adverse, which causes lack of benefits in terms of reduction in cardiovascular events, not intensive blood pressure targets. Intensive blood pressure control does decrease major cardiovascular events. The event-free survival rate is better with intensive blood pressure control, even when stratified according to secondary outcomes, whether it's major coronary events, stroke, or heart failure. But you can see that heart failure was non-significant, major coronary events were non-significant, and all-cause death was non-significant. The primary outcome, as we saw in the previous slide, was significant. The only secondary outcome which did show statistical significance in the study by Sugimoto and Kajio was stroke. Event-free survival rate, when stratified according to stroke, was statistically significantly better in the intensive blood pressure target group. But this non-significance, this lack of significance of secondary outcomes in the comparison of intensive blood pressure treatment and standard blood pressure treatment groups in the study by Sugimoto et al. Is likely due to the fact that the ACCORD-BP trial was underpowered. The ACCORD-BP trial was designed to have 94% power to detect 20% reduction in the rate of the primary outcomes. Assuming two-sided alpha level of 0.05, a primary outcome of 4% per year in the standard blood pressure treatment group would be expected. However, the observed primary outcome rates were 1.87% and 2.09% per year in the intensive and standard blood pressure treatment groups, respectively. So, ACCORD-BP was underpowered, and the re-evaluation by Sugimoto et al. Was also affected by this underpower. Of course, these large trials are never powered for subgroup analysis, but if you look at all the subgroups, whether it's age, sex, obesity, duration of diabetes, history of cardiovascular disease, use of insulin, hemoglobin A1C, or systolic blood pressure, all the hazard ratios are in favor of intensive blood pressure treatment, even though all the p-values are non-significant. Further support for the argument that intensive blood pressure targets reduce major cardiovascular events in type 2 diabetics comes from this study by Bedou et al. From the Journal of the American Heart Association, also from 2018. To recap, in the SPRINT trial, intensive blood pressure targets reduced the incidence of cardiovascular events. Again, in the standard glycemia arm, intensive systolic blood pressure targets reduced cardiovascular events. In the intensive glycemia arm, the reduction of cardiovascular events is not seen. So again, it's the intensive glycemic target that is problematic, and intensive systolic blood pressure targets do have benefits of cardiovascular event reduction. And we'll see more data on that in subsequent slides. Again, in the SPRINT trial, the incidence of all-cause death was decreased with intensive blood pressure targets. Incidence of all-cause death is also reduced with intensive systolic blood pressure targets in the standard glycemia arm. But the incidence of all-cause death is increased in the intensive glycemia arm. Here you can see that the hazard ratios for the composite cardiovascular endpoint are in favor of intensive blood pressure targets in the SPRINT trial, in the standard glycemia arm of the ACCORD BP trial, as well as in the combined glycemia arm of the ACCORD BP trial, but not in the intensive glycemia arm. And as far as all-cause mortality is concerned, again, the hazard ratios are in favor of intensive blood pressure targets in the SPRINT trial, in the standard glycemia arm of ACCORD BP trial, but not in intensive glycemic control or in the combined glycemia arm. And if you look at the p-value, when you compare the SPRINT trial to the standard glycemia arm of the ACCORD BP trial, the p-value is 0.87, showing you that the data or the results from the SPRINT trial are actually very similar to the results that you get in the standard glycemia arm of the ACCORD BP trial. Finally, if you look at the results on glycemia intervention versus after discontinuation of glycemia intervention, you can see that on glycemia intervention, the incidence of cardiovascular endpoints is greater with intensive blood pressure targets. But after discontinuation of glycemic intervention, the incidence of composite cardiovascular endpoint is actually less with intensive systolic blood pressure target. And this is the same with all-cause mortality, which is greater in the intensive blood pressure target on glycemic intervention versus improved after discontinuation of the glycemia intervention. And in the standard glycemia arm of the ACCORD BP trial, again, this shows hazard ratios in favor of intensive blood pressure targets when stratified by composite cardiovascular endpoint, as well as with heart failure. Again, the hazard ratios are in favor of intensive blood pressure targets when stratified by cardiovascular death, myocardial infarction, as well as stroke. And the findings in stroke is significant not only in the standard glycemia arm, but also in the intensive glycemia arm. So to recap, ACCORD does have some strength. It was a large, diverse patient population with type 2 diabetes. There were frequent follow-ups. There was focus on high-risk patients. And the study's follow-up continued even after the active treatment phase, allowing for the assessment of long-term effects of the interventions. To recap, what were the flaws of the ACCORD trial? First and foremost, ACCORD trial was underpowered. The event rate observed in the standard blood pressure treatment group was 50% lower than the expected rate. Information about the type of stroke was not provided, so effects on ischemic versus hemorrhagic stroke remain unclear. What we do know is that the incidence of stroke was reduced in the intensive blood pressure target group regardless of whether they were randomized to the intensive glycemic control group or the standard glycemic control group. Blood pressure targets were not studied in low-risk patients, so the ACCORD trial does not elucidate whether intensive blood pressure targets or standard blood pressure targets are better in patients who are lower risk. ACCORD assumes minimal or no interaction between glycemic control and blood pressure control, and this is the major flaw. The intensive glycemic control arm was associated with adverse events, with increase in major cardiovascular events. Intensive blood pressure control is associated with decrease in the primary outcome and in major cardiovascular events, as was shown in the SPRINT trial and as was subsequently shown in the standard glycemia arm of the ACCORD BP trial. Important points. Intensive systolic blood pressure lowering reduces the risk of cardiovascular events and all-cause mortality in the standard glycemia arm, but not in the intensive glycemia arm of ACCORD. Deleterious effects of intensive systolic blood pressure lowering in the intensive glycemia arm dissipate after discontinuation of the intensive glycemia intervention. Intensive management of either systolic blood pressure or glycemia alone improved major cardiovascular outcomes per a previous ACCORD BP report. Similar findings were noted by Bedou et al. So how can we make sense of all of this? What's the biological plausibility that intensive glycemic control should be associated with adverse increase in major cardiovascular events, especially if an intensive systolic blood pressure target is pursued? Compared to non-diabetics, adults with type 2 diabetes have diminished myocardial glucose extraction and utilization despite similar levels of plasma insulin and higher plasma glucose. This may limit the ability of myocardium in type 2 diabetics to withstand ischemia, especially in the setting of intensive systolic blood pressure lowering. In summary, intensive systolic blood pressure target of less than 120 millimeters of mercury is beneficial in patients without diabetes and with diabetes on standard glycemia control. Combined intensive glycemic control and intensive systolic blood pressure targets result in increased cardiovascular events and all-cause mortality. The interaction between intensive glycemic control and intensive systolic blood pressure target dissipates after discontinuation of the intensive glycemic control intervention. Taken together, ACCORD and SPRINT both support intensive systolic blood pressure target less than 120 millimeters of mercury in patients without diabetes and in patients with type 2 diabetes on standard glycemic control, i.e. goal A1C less than 7, not goal A1C less than 6.0. In the next volume of the Hypertension series, we will do a review of the MDRD trial, discuss its strengths and weaknesses, discuss how it contributed to the establishment of blood pressure goals, discuss what remains unknown or uncertain. In particular, the kidney-specific trials, like the MDRD trial, in which kidney events were significant but cardiovascular events were not significant. We can draw more conclusions about chronic kidney disease, progression of chronic kidney disease, and acute kidney injury, as well as end-stage renal disease. All of the talks in this hypertension series will end with a couplet of the month. The couplet of this month was by Robert Frost. Two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference.